Well, my name is Kara Foster. I'm the Education and Training Manager at City Match, and just want to thank everybody for joining us today for this really timely and exciting webinar. We are pleased to have Kay Johnson joining us. Kay has been a longtime friend of City Match and has contributed her expertise to the field and to our work in many ways over the years. Over the past 35 years, Kay Johnson has become nationally recognized for her work in maternal and child health as an advocate, researcher, and consultant. Reducing the impact of poverty and racism and increasing access for women and children are two of her lifelong goals. Kay is president of Johnson Group Consulting. Her expertise encompasses a wide range of issues. Her work at the Children's Defense Fund, March of Dimes, George Washington University, and Johnson Group helped to shape the direction of MCH and Medicaid policy since 1984. Prior to her policy career, Kay worked with families in early care and education. All right, take it from here, Kay.
Great, thank you. Well, I'm going to turn off my video so I can concentrate on my screen, but I'll turn it back on when we're talking. And I really want to thank everyone for joining today. I'm really excited to talk to you about this. I've been talking to some other local leaders, but you really are, more my favorite audience of people who are local MCH leaders, and that's what we're going to talk about today: is your role in advancing policy opportunities to improve child and family health and well-being. And thanks to the City Match staff for inviting me to do this and be a part of your learning network. So we're going to start with a poll, and it's going to talk about how do you relate to policy? Are you a policy entrepreneur who's always working on policy? Are you a maven who follows it closely or engage in politics and policy development? Are you a policy implementer who plays an active role in government implementation? Are you a dabbler who occasionally follows one or more issues? Or are you a rookie? You don't usually think about policy or politics. You would say, it's not my thing. So I don't see the poll. I don't know if others do, but it's okay to put it up. And that's a picture of me shaking hands with President Clinton in the Oval Office after the veto of the Medicaid block grant in December of 1995. It was one of the coldest days in the year, but about 30 of us gathered there as poverty for children and seniors and families, and really to thank him for vetoing the Medicaid block grant that had been passed after the Gingrich Revolution. We've seen a lot of challenges since then. So I'm seeing in early results that we have a kind of a majority group of dabblers, but we do have some other policy entrepreneurs and policy mavens and those who see their role as implementers. Not surprisingly, I don't usually get the biggest audience for policy rookies, but thanks for joining today. And I'm sure that you will learn something that can be useful to you in this process. I think we all have different roles, and I think, whether you just follow climate change, or you are in government and you're implementing the policy, or you're following everything closely, even if it isn't your work, those are just a lot of different ways that we as citizens, as concerned family members and others do this. So I leave it to you guys to end the poll. We've got about 7. Great. So the majority are dabblers. And so this will really give you, I think, a lot of information you're interested in, but also in every category. So I'm going to start by thinking a little bit about what the COVID-19 emergency has meant for children and families. And what we know is it's disrupted the lives of virtually all children and families, and greater challenges were faced by those who were already more vulnerable. So just as an example, these are the data from this February 2021 of children in households of color who were more likely to experience food insufficiency during the COVID-19 emergency. And you can see It's almost 30% of Black children, about a quarter of Latinx, and compared to only about 10% of white children who experience food insufficiency. And that's just one indicator of the ways that families were affected. These are the data about the pregnancy risks and how they were more severe for women of color. So CDC recently reported data about 1.3 million women of childbearing age who had COVID-19. A little over a third of them had lab confirmed cases. And of those, they were almost 9 out of 10 were symptomatic cases. And out of those, about 6% were pregnant women. And out of the pregnant women, these are just startling results. I think they should be for all of us. They were 3 times more likely to be admitted to the ICU, particularly Asian American and Pacific Islander women, who were more than 6 times more likely to end up in the ICU as a result of COVID when they were pregnant. They were almost 2.5 times more likely to need and receive invasive ventilation. And they were 1.7 times more likely to die. And it was for Black women, 1.4 times, and for Latinas, 2.4 times more likely to die as a result of COVID. So while for a lot of us in MCH, we've thought about the past year of, oh, well, it doesn't seem to be a lot of transmission to the baby. Maybe this isn't so high risk. What we can see is that for the women who got sick, particularly women of color, this was really a serious problem. We also often think about, the status of our children. And I've defined these risks as related to people's socioeconomic status and racism. And so in the lower right corner, you see the distribution of children birth to 17. These are 2019 census data by race ethnicity. And you can see only about half of children self-report as white, not Hispanic. And then up in the left-hand corner, you can see the distribution of those children who live in poverty by race ethnicity. Again, going from 10% of white children to 33% of Indigenous children, and the risk of living in poverty for children of color. And then on the lower left side, we see for the same color bars, the COVID-related hardships among households that had children. And you can see in the 1 to 2 range, children of color were somewhat more likely. In the 3 to 4 hardships, they were particularly Black children were about twice as likely as Asian or white children. And look at the category of 5 or more hardships. And clearly this is related to the fact that their families started and already living in poverty, living in communities where there were higher risks. I hope I am now unmuted. Can somebody signal?
Yes, you are, okay.
Great. I just want to go a little deeper into this, thinking about urban areas, and I want to tell you, you can get your own Child Opportunity Index maps at diversitydatakids.org. I just pulled a few for today for us to think about. This is the map of Greater Omaha, and it's showing you an overlay in the yellow dots on the map of the concentration where Black children live. The lighter the color on the map, the lower the opportunity index for that census tract neighborhood, and so on. And what you can see is that almost half of the Black children in metropolitan Omaha live in an area where there is a very low child opportunity index. These are data. I went to Milwaukee to get an urban area that had a somewhat more intense Indigenous American Indian Alaska Native population. So you can see I have both the yellow dots for the Black children and those kind of fuchsia dots for the Indigenous families who are really highly concentrated in a few neighborhoods. clearly something going on there with housing availability for those families. But you can also see again here, the scale is to 50% and the extent to which they are likely to live in a neighborhood that has very low child opportunity levels. You can also see how much of Milwaukee is an area with a very low opportunity level as opposed to going out there in the suburbs. So we have an opportunity to use policy and other supports to ensure equity and to shift from negative to positive social determinants of health. And what we really need is public investments that reduce poverty and boost opportunity, that provide for basic needs such as food and housing, that assure health across the life course, that promote health and positive experiences at home, at school, at work, and in communities, that support and strengthen families, and that ensure children are launched on a trajectory for lifelong success. This diagram on the right is just a simple interpretation of the factors that the World Health Organization used in its frame for structural determinants, where we want to boost opportunity, social justice, and income and intergenerational wealth at the policy and societal level. And then intermediate determinants that are more about material circumstances, such as living conditions and safety and well-being at home and in the community, and family strengths and positive experiences. And then direct care determinants. In this example, in the health system, we want to reduce unequal treatment and increase access to high quality, comprehensive team-based care. Policy has an influence on all of those things. So let's go to another poll. I'd like to learn a little bit more about you. You can go ahead and put the poll up. And just let me know if you're working at a health department, you're an epidemiologist, analyst, or researcher, you work in a community-based organization, or you're a community leader, you're a service provider, such as a home visitor, or a physician, or a nurse, or you're a policy advocate or activist in your community, or you play some other role. So not surprising, we've got health department staff in the lead, with epidemiologists, analysts, and researchers coming in, and we also have a fair number of people who are coming in at other. Okay, I think we've slowed down enough. Let's go ahead and move on. Definitely health department staff in the lead. So a lot of what I'm going to talk to you about today is in the American Rescue Plan. And this is just kind of a rip from the headlines view about the American Rescue Plan. I like that up on the upper left, we see the headlines that my Senator Bernie Sanders put out to promote the passage of the American Rescue Plan. And what you can see down here from Fox News is that they were underscoring similar elements of the rescue plan. This is the cover of the rescue plan and the president signing it, and communication from the White House using data from Columbia University. I'm going to show you more of that, that if passed, the American Rescue Plan would, and I'm going to say to you could, cut child poverty in half. And then this graph on the bottom from the Nonpartisan Congressional Budget Office that shows you the distribution of the resources. So the largest big purple share went to the $1,400 relief checks. The next, this sort of light green, minty green, was state and local aid. And then the federal unemployment insurance add-on is the next biggest wedge. The tax credits and other aid for families, we're going to talk a lot about, is the next largest. Money for education, for the COVID relief campaign, vaccinations, and healthcare. And then most of these smaller wedges are particular businesses or other audiences. So this is the biggest shift in child and family policy in many years. Some would say 60 years since the Great Society of President Johnson, and some would say 85 years since the New Deal of President Roosevelt. But I also want to underscore that this is a shift toward policy that's designed to help a wider array of families. It's more like a European approach that we've traditionally thought about it. It doesn't have such dramatic cliffs. It doesn't require that it be a single parent family. It doesn't require that every family that gets assistance is among the very poorest of families. So it really changes the way that assistance to families from the government is designed in a fundamentally and important way. But we know, first of all, that families whose lives have been immediately disrupted could see immediate relief. And we're going to talk about the details of that. And we also know that the American Rescue Plan Act has many one-year improvements. It puts us on a pathway to end child poverty within a generation if, and it's a big if, these policy changes can be made permanent. And I'm just going to point out to you that I use American Rescue Plan to talk about what the president proposed, and I use the American Rescue Plan Act to talk about what Congress passed and the president signed into law. So thanks to Charlie Bruner for letting me use this nice chart that he put together about the American Rescue Plan Act investments in women, children, and families. And you can see those numbers on the right are in billions, and some of them highlighted as they relate to the MCH population, but all of them related to children and families. We're going to talk more about these, but I wanted you to see kind of the scale, the size of these investments at a glance. So I like to put this in 4 buckets. The first one is about economic relief to families with children, and that has to do with quite a number of tax credit provisions, as well as the $1,400 relief checks. Then assistance with basic needs. That includes cash assistance, childcare, utilities, food. I put home visiting here, and housing. And then protecting health, particularly the vaccine campaign, but other COVID investments, Medicaid expansions, reduction in Affordable Care Act premiums, investment in the workforce and safety net providers, and pediatric and other mental health investments. And then a bucket that's about opening education settings safely and getting kids back to school, particularly those hardest hit. So we're going to talk in more detail about these 4 buckets. We're also going to talk about your to-do list. And so this is kind of a generic to-do list across all of these buckets. I would say find out how the policy changes may impact your state and community. Understand how these policy changes affect programs or services for women, children, and families. Informed decision-making about the implementation of these funds, particularly at the state or local level. How are the funds going to be used and how will they affect the MCH populations? Train staff such as navigators and care coordinators and home visitors so they can help you educate the people you serve about the opportunities that are in this act. Connect people to other resources and use community partners to help and inform and engage people, particularly trusted messengers. So starting in my first bucket about income support, this one you heard about, probably the child tax credit, which raises to $3,600 for children under 6 and $3,000 for children 6 to 17. And it also makes it what policy wonks call fully refundable, which means that there are millions of families who could not take advantage of the child tax credit because they hadn't paid in enough taxes, who now can. Similarly, more people helped by the earned income tax credit, the child independent care tax credit, and unemployment, as well as tax credits related to family leave. So on your to-do list is to understand the basic differences and the changes in these various tax credits, inform families about tax credits opportunities, inform them about family leave opportunities, and connect families to legal aid partners, volunteer income tax advocates, or other resources. A few years ago, when we were doing the infant mortality coin on social determinants, some folks in Wisconsin did a really good project where home visitors helped connect families to volunteer income tax advocates when they were screened and they wanted to explore their opportunity under the earned income tax credit. So you could find out about those in your community. I'm going to talk more about the child tax credit because it is the biggest piece. The first thing to know is that while we talk about this a lot as saying half of children can be lifted out of poverty, that's true. At the same time, 90% of all children will benefit from the child tax credit. And among those, this 27 million who can be lifted out of poverty. So you see on the left, the all children, the current rate to the rate with the child tax credit, and you can see how that's almost half. And then you can look at the dramatic impact for Black children, for Latinx children, still, while at a much smaller scale, even a dramatic impact for white children. So 90% of all children in almost every state, as well as for the whole country. Families could start getting these benefits as soon as July, getting a $300 a month check. They don't have to wait till they file their taxes, and we can help them get ready for getting those checks in their mailbox in this time. There are also concrete supports for families. First and foremost, relief checks and the enhanced unemployment, which I've mentioned, but also emergency assistance in terms of income, food, childcare, housing, utilities. Your to-do list is to inform families about emergency assistance and to confirm that they got their COVID relief check. This week, I saw a new posting from the Biden-Harris administration from the Treasury Department, new ads saying to families, you should have gotten your COVID relief check. If you didn't, visit this website. So we can help families know that they should have gotten their money, and if they didn't, that there's a place to go check. Connecting families to WIC, to SNAP for food stamps, to TANF income support, to housing relief, and so on. And using community-based organizations and other resource partners who work specifically on these areas of assistance in your community to help connect families. I want to spend a minute more on the food opportunities, in particular WIC. This is a short-term opportunity. It ends at the end of September of this year, but for the summer, this allows states to increase the WIC fruits and vegetables benefit by up to $35 a month. It currently is only $9 per month per child and $11 per month for women. So this is a really big increase in fresh fruits and vegetables for them. The opportunity for states to have this fully funded, the extra costs, as well as to spend money on outreach, enrollment, and modernized delivery methods and new ways to do electronic benefit cards and that sort of thing. But these additional funds for WIC, as well as the additional funds for SNAP and food stamps, must be distributed by September 30th, 2021. So this really requires action and uptake for families. The Biden administration has a number of priorities in terms of health coverage. This is my second, the third bucket. And so they've issued executive orders, agency action, and legislative proposals. The biggest one from us today is about the special enrollment period for the Affordable Care Act plans. It has been extended to August 15th of 2021. We know a lot of families who lost their jobs, lost their health coverage. And there's a hotline as well as really going to the websites. What I can say is that the American Rescue Plan Act lowered the premiums for most of those enrolled in Affordable Care Act marketplace coverage. So even people who have coverage may be able to get a lower premium in the special enrollment period, and people who checked and couldn't afford it may see that the premium is half of what it was the last time they checked. So you can, and you can help others, check out healthcare.gov and your insurance marketplace website. If you go to healthcare.gov, it'll link you to your state's insurance marketplace website. You can assess the need for coverage among the families that you serve. You can inform families about the special enrollment period. There are some ready-made documents, but there are also some good websites. And you can assist families with online enrollment process. for most cases, for families to get this coverage, they're going to have to go through an online enrollment process. We know that's not easy for everyone because of the digital divide. They may not have broadband access. They may not be good at filling out forms online. So getting them the assistance with enrolling will be really important. So let's do another poll. You can go ahead and put it up. I want to know if, in terms of Medicaid, you consider yourself an expert at the national, state, or local level, whether you advocate at the national, state, or local level, you deliver services paid for by Medicaid, you understand somewhat, but you want to know more, or you don't really know any specifics about Medicaid. Looks like people want to know more. That's good because I'm going to talk about it some more. I also have some advocates and some experts joining us today. We'll look forward to comments from all of you when we get to the discussion. Great, let's go ahead and close the poll. So it looks like a lot of people want to know more, but again, we have some expertise and some of you are delivering services, so you're providers for this. Some of you may know I've spent a lot of my working on Medicaid and improving it for women and children. I'm really excited about what's in the American Rescue Plan Act. And first of all, that's the state option to extend postpartum Medicaid and CHIP coverage for women who had a Medicaid financed birth. There's also a 5% increase in FMAP, that's federal matching, for the new ACA Medicaid expansions to try to get states that haven't expanded, give them another little boost and an incentive to do so. There's mandatory coverage of COVID vaccines and treatment with no cost sharing, as well as some other protections for people related to COVID. And there's an increase in matching for home and community-based services, which may be particularly important to people, adults with disabilities or children with special health care needs. So your postpartum to-do list is to support postpartum Medicaid expansion in your state, and I'm going to talk a little bit more about why. To learn more about postpartum coverage loss among those you serve, those who live in your city, those who live in your state, and to help birthing people get timely postpartum care. Only about 60% of the people who have Medicaid coverage actually end up getting their postpartum visits in a timely way. So what do we know about new mothers who lose Medicaid, who lose coverage postpartum? And what you can see on the right is a graph from an Urban Institute analysis, and you can see that almost half of mothers who are uninsured with a new baby are uninsured because they lost their Medicaid coverage postpartum. And that's because if you weren't on Medicaid before you got pregnant and you got on Medicaid because you had pregnancy-related coverage, that you are currently likely to lose your coverage 60 days postpartum. And that was the existing federal law until the American Rescue Plan Act. Half of these mothers have below poverty income, half are Latinas, 2/3 are citizen, about half are married, and another quarter live with a partner. And while 1/3 are employed, 59% were not in the labor force, and this was before the pandemic. So I suspect that that last item in particular has changed as people lost their jobs. States have a lot of complicated decisions to make about Medicaid expansion for maternity care, for family planning, for prenatal coverage, for coverage of labor and delivery, and for postpartum care. This is from the Kaiser Family Foundation, their 2020 map on a bunch of these decisions. So you can see, for example, in the dark blue, those are Medicaid family planning programs, and states have Affordable Care Act Medicaid expansions. In the medium blue, they have an Affordable Care Act Medicaid expansion, but no special family planning program. In the light blue, they have a state family planning program and an ACA expansion. In the gold, they have only the family planning waiver. There's no Medicaid expansion for those women of childbearing age, particularly those who haven't had a first pregnancy and have a child, or who aren't extremely poor. And then the red is no ACA expansion and no family planning program in 3 states. And what we're coming to now, in my little bubbles on the right, that Illinois became the first state to have a waiver approved for 12 months of continuous coverage for women. And congratulations to all the advocates in Illinois who worked very hard on this. They're now working to go beyond the waiver to get a state plan amendment approved. But this was announced a couple of weeks ago by Secretary of Health and Human Services Becerra. Washington State and West Virginia have legislation passed that gives them permission to begin work on a waiver or a state plan amendment. And in Florida and Maryland, they have legislation pending, which I hope will soon be signed, to go forward with a postpartum expansion. I want to talk for a minute about why the state plan amendments are better than the waivers. A lot of advocates, because there was no choice to do it in Illinois, worked really hard to get a state waiver proposal submitted. And yet now, with the opportunity for the state plan amendment, or the SPA, as it's called, there are various advantages. The first is that when states use the SPA, they have to provide full Medicaid benefits. Waivers often provide a narrower set of benefits. The funding in waivers, they have to be budget neutral, no new money, and the SPA would provide federal matching funds for additional spending. Some waivers focus on only a share of populations, such as women who are substance users. And in the SPA, it would be the whole population, and more birthing people would be included. In states that choose the SPA, that coverage would apply to those who are CHIP enrolled birthing people. That's only 6 states, but it will matter in those states. The waivers permit states to waive certain federal standards. That's part of the notion of these waivers. And if they use a state plan amendment, they have to give protections like choice of family planning provider and no cost sharing and statewide-ness. And I think of it really as a 2-gen opportunity. The SPA provides for 1 year of continuous coverage for birthing people, which is parallel to the coverage that their infants have following a Medicaid financed birth. So think of what it means for us to have the mom covered for a year, the baby covered for a year without interruption, and the opportunity to provide services that support them together. Earlier this year, I issued a report about missing babies in Medicaid. Federal law for several decades has guaranteed automatic and continuous enrollment for babies born with a Medicaid financed birth. In other words, they shouldn't have a break in coverage from the date of birth through the first year of life. But too many babies fall through the cracks in the enrollment process. So your to-do list on these babies is to review the missing babies report. There's a blog version, there's a 4-page summary, and there's a full report that even includes contract language and a review of what states' best practices might be. You can check your state website. I did a review of all of the state websites. They're quite variable. Sometimes the fact that the baby will be covered is only on the pregnancy website, not on the child website. Sometimes the information on the website is wrong. So you might check, what does your state's website say about guaranteed automatic and continuous enrollment? They shouldn't have to reapply. They shouldn't have to go through an eligibility determined process. You can inform families about automatic and continuous eligibility for infants, and you can help families confirm that their infant is enrolled. In many states, there's a way to do that online. Washington State has a really terrific system for that. So I just want to emphasize for those that don't Medicaid closely, that improving Medicaid and the associated CHIP programs is essential to our goals of equity. More than 6 in 10 Black, Native, and Hispanic infants are covered by Medicaid and CHIP. And that's the dotted line is the 46% average. but you can see how disproportionately important Medicaid is to children of color, and that's because their families are more likely to be poor. In addition, over half of all Black, Native, and Hispanic children from birth to 18 are covered by Medicaid. I've been saying a lot, we can't have health equity if we don't have Medicaid working well, providing quality services, and covering the things that families need, pregnant women and children in particular. The American Rescue Plan Act also talks about public health and community workforce, with billions for the public health workforce, things like the National Health Service Corps, the Nurse Corps, the dental placements, billions of dollars for public health agencies, and almost $48 billion for COVID testing, contact tracing, and mitigation. You need to learn in your to-do list about your state's allocation and what are its plans. You need to encourage the hiring of people like family specialists and community health workers that will work with families who have children or pregnant women, not just hiring people who will go to nursing homes or work with adults with chronic conditions. You want to encourage a workforce development that supports families with young children. There's funds to support the healthcare safety net with $7.6 billion for community health centers, also known as federally qualified health centers, money for community mental health, funding for family planning. In particular, your health center's to-do list is to find out if the health centers in your area use medical legal partnerships so that they might help some families get connected to these related opportunities, and inform families about access to care for uninsured adults and children via those federally qualified health centers, particularly for those who are undocumented. The American Rescue Plan Act has pediatric mental custody, and I'm not going to go into the details of this, but it's up from 9 million to 80 million to have more pediatric mental health teams. This is money that will come from the Maternal and Child Health Bureau at HRSA, and you can learn about your state's plan and allocations. I've given some links in the slide. You can encourage a focus on early relational health promotion and infant and early childhood mental health, not just on the health of older children and adolescents, and support the development of teams that focus on parent-child dyadic services for the youngest children, for those moms and babies together. There is additional support for home visiting, an expansion for the maternal, infant, and early childhood home visiting program by $150 million. Again, really through a little over a year. A lot of flexibility in this funding for virtual visits, for hazard pay and staff costs, for devices and connectivity for families, for remote visits, and emergency supplies related to diapers, formula, food, hand sanitizers, and even gift cards to purchase fresh groceries. The American Rescue Plan Act has a lot of investment in early care and education through the Child Care and Development Block Grant with child care subsidies, with $24 billion to stabilize the child care market, $1 billion for Head Start, and those child care tax credits I talked about earlier. If you're like me, you're hearing a lot about the importance of investing in childcare. I think we all need to speak up about the importance of investing in health and the health and well-being of our pregnant women, new moms, and babies as well. It's absolutely as vital as childcare. There is money for the Individuals with Disabilities in Education Act, if that's an area of your concern, for special education, for preschool special education, and for the Part C early intervention program for infants and toddlers. And on the Part C program, you should review your state's policies and eligibility criteria and check out what your state's going to do with that additional money. It is substantial money in most states. And inform families about Part C early intervention services in general and help them through the process when needed. What we know is that on average, from the time of a developmental concern till the time a child gets fully enrolled and served in Part C is often 8 months, which can be half of that child's life. There is funds for reopening and supporting schools with emphasis on equity and support for the hardest hit schools, relief for K through 12 schools. I didn't mention on this slide, but of course, higher education and pre-K as well. So I wanted, in addition to what I said about the American Rescue Plan Act, I want to talk about some other opportunities ahead. I think at the macro level, the question is, can we use these investments to extend support for families in the COVID-19 public health emergency now, before they're evicted, when they need food, when they need health insurance? And how do we advance these investments across all the areas of early childhood systems, of perinatal systems, and other maternal and child health systems? And then can the child tax credit and the other provisions be made permanent? Part of that may be through the American Families Plan, which I'm going to talk more about in a minute. But if you just think about the sum total of this, is what we need to show is that families needed these resources, that they were wisely used, and that they made a difference for families. And I think for those of us as public health professionals concerned about maternal and child health, this is really a very important issue. If the Biden-Harris administration gets Congress to make all of these investments and the money doesn't get used, that is not a good sign for future investments. The American Families Plan was introduced by the president back a couple of weeks ago, and there you see Madam Vice President and Madam Secretary and the President at that address to Congress, where he released this, making the child tax credit and other tax credits permanent, providing assistance and support through childcare, paid family and medical leave, which I know many of you have long been concerned about, nutrition and food security, unemployment, and Affordable Care Act health coverage credits and premiums, as well as boosting education access from universal preschool through college. And you can see there the first focus on children has a nice 8-point list that in some way parallels what I've just described to you. This is a plan the president has released, which will be deliberated in Congress. I think holding on to some of these big items and making some of these changes permanent is going to be really very important. Overall, I would say to you, this is a time we can go farther and we can do better. You know that what we've been doing has been incremental and limited by our socio-political context. We've not been investing in whole families. The policy hasn't been necessarily reflective of the voices of women, parents, and families. We've not been acknowledging or addressing bias and racism in the kinds of policies that we enact. And we've not been sharing power with women, families, and communities. I'll just take, for example, one of our opportunities ahead is to look at what did the maternal health bills introduced in the last session, and some are being reintroduced now, including the Momnibus. Where was the focus? The focus was on coverage. So we've got that postpartum coverage option for states, but maybe that can be turned into a mandate. Having incentives and innovative payment models. And then quality, using our perinatal quality collaboratives and having anti-bias, anti-racist provider training, diversifying the workforce, having more care coordination in pregnancy and medical homes, using our data and quality measurement strategies, particularly digging in on the equity issues, and making grants to states to implement best practices. A lot of you know that's a program called AIM currently, and there's a lot of call for more investment in that. There's also a set of things that are related to social determinants of health and their role in maternal health and maternal mortality and morbidity. And the Momnibus calls for an interagency task force on social determinants, as well as reports from the National Academy of Sciences, the Government Accountability Office, the Departments of Health and Human Services, Veterans Affairs, Agriculture, Justice, and so forth. It also calls for investment in community-based programs that are maybe non-traditional grantees that are administered by Black women or have doulas or really are on the ground. Those are the kind of priorities that we could be moving in this Congress. We're going to need layers of change if we're going to address unequal treatment. We need to improve coverage and benefits and reduce costs. We also need to address the role of racism in access to equitable care for Black, Indigenous, and other people of color. We need to implement practice guidelines fairly and equitably, adopt anti-racist, anti-bias approaches in healthcare, and design quality improvement efforts with an equity lens, not just a generic effort that measures disparities at the end. These data on the right from PRAMS show you about preconception advice and services. And first of all, look how low advice on achieving or preventing pregnancy preconceptionally is. That we're looking, the whole scale's only 8%, people, but we're looking down in that 1 to 2% range. But still, for the Black women, the Hispanic women, and women of other multi-race, lower than for white women on getting that kind of advice. And then look at the dramatic shift over in whether or not the women reported they received a service that supported their preconception goals and the advice that they had been given. The things that are in the advice and the things that are in the services are national recommendations. They're standards of care in obstetrics and gynecology. And yet we know they're not being equitably distributed. I have 5 more graphs like this that I could show you. We have to start showing the data and measuring quality and measuring equitable access. You, I think, are leaders who can have an impact on the future. I'm encouraging you to act with urgency. Many of these opportunities are for 1 year. Help guide the decisions in your state or in your community. Implement the policy from your role, whether that's as a community activist or someone who works at the health department. Assist birthing people and their families in understanding and benefiting from these changes in policies, and educate decision makers about the importance of social determinants of health and the importance of responding to concrete needs. The fact that we've seen an increasing number of states turn down that supplemental unemployment insurance means we really have to make our voices be heard on these issues. I think putting the pieces together, what's passed in the American Rescue Plan, what's proposed in the American Jobs Act for the workforce and infrastructure, what's proposed in the American Families Plan, what if we could leverage all 3 of those across systems to address social determinants of health? How could we affect all of the areas that I'm showing you on the slide? We could do it. The money is there. The president's calling for the investment. The Congress is trying to move. So we have these investments. We have one big set now of $1.9 trillion. And we need to show that these funds can be used widely and that they can be used to make change. So I say that MCH local leaders can leverage these investments using the American Rescue Plan Act, the American Jobs Plan, and the American Families Plan, and other investments to build a stronger early childhood and perinatal systems. You have the community partnerships and leverage to make change. You are the ones most likely to be able to braid and blend funds, and you are at the point of inflection. I would just say I've heard that term a lot, and when I started to put it at my slide, I thought, do I really understand what that means? So here's the little diagram about the point of inflection. It changes from the downward curve to the upward curve. So let's be that point of inflection, and let's get together and make these resources available to families to address their needs. I really appreciate having a chance to talk to you all. If people want to turn on their cameras and be seen, I'm going to do that. And I'm going to open up the chat. I bet there's a question or 2. Thank you. Thank you for the comments on the to-do list. I see several people from Indiana looking at that opportunity to take advantage and extend postpartum coverage. I'm backing up here. Maria, on slide 19, the WIC increase is for children and for women. It's $35 now a month for both the pregnant women, postpartum women, and the children. Let's see here. Just trying to go down. So Amy says, if you're looking for good state-specific information, try your PRAM survey. I agree with you, Amy. Michigan's got great PRAM state. I use you in my examples. Amy, do you want to talk about that for a moment?
Sure, okay. If any of you are thinking about what you can do to add to your postpartum extension conversation, so if that's a conversation you're trying to add some state context to, we have just found that looking at PRAMS data is a really good way to talk about what is happening for women in that postpartum period, because think about it, that's when you're asking the PRAMS survey. So it's very much focused on that time period. You know, things like at least in our state, we have a Republican legislature. So really talking about how many women had their employment impacted against their will. So we highlighted that 11% of women are fired or have their hours reduced during pregnancy. So if you think about insurance being based on employment, largely those women had those things done to them, and probably are not going to get another job or another form of insurance during the pregnancy. So it gave us an opportunity to really talk about the fact that these are working women who are eligible for Medicaid, who we're trying to extend coverage for. And I think it changed the dynamic a little bit. The other thing I'll say real quick that we used that I thought was really helpful, there's a lot of misconceptions among legislators about who accesses Medicaid during pregnancy. And so it's relatively easy to find through, we use the kids count data through NEKC, but you can find by county in your state the number of women who are on Medicaid at birth. And it usually presents a pretty interesting picture for some legislators who think they know their district and maybe they don't.
And they don't realize that on average about half of the births are financed by Medicaid. They're thinking about some reality from 20 years ago that isn't today's reality. So both Amy and Sally are raising an important issue. I'm encouraging people to take action now to get what they need in place. If they need legislation, or if they need the appropriation before their legislature goes out, don't wait to have that fight next spring. Get that money now if you can, get that authorization now if you can. Some people said, well, CMS didn't really even tell us what to do yet. Well, you're going to need money. And if your legislature has to give authority, then you can work on that. And you can worry about the specifics of the plan that your Medicaid agency submits in a couple of weeks or months when the Centers for Medicaid and Medicare Services releases their guidance on the form, how they want the plan to be submitted and all of that. Amy, you got the appropriation?
Yeah, we have it in the current year. We have to keep it obviously for our next fiscal year, but we're working on it.
That's great. And Sally, do you want to talk about Indiana? Let's see, Sally. Oh, there's Sally on my screen.
Oh, I can't, there I am. Hi. I honestly found out about it on Twitter from a reporter. It got done just before our session ended because we have a part-time legislature. So they were done, towards the end of March or April. But I think our FSSA secretary was real instrumental in that. And then also it was one of the main recommendations of our maternal mortality review committee. So I think that had a lot to do with it. So they just went ahead when they were doing the budget and got that in there, but no one knew that was happening. So it was a nice surprise.
Yeah, it's good. There certainly are some people in positions in Medicaid and related agencies who have that opportunity and again, though, if that's not happening automatically with your state officials, using your PRAMS data, using your coverage data, using the data about how many women lost their employment and might be having a baby. Use the data from your maternal mortality studies, which many of you have done. You have a lot of information that can help you make these cases to the legislatures or to the agencies where that needs to be done. And Maria's noting about disaggregating data to address health disparities. Obviously, there's some levels at which we don't have that data, but at a lot of them we do. Not at the national level so much, but in your state PRAMS databases, many states you can get that data about coverage and coverage loss and when Medicaid was covering by race and ethnicity. A few years ago, I did a whole training for City Match teams about how to use their PRAMS data to look by race and ethnicity about who was covered before pregnancy, who had prenatal coverage, who had coverage only at the time of labor and delivery, and then who lost the coverage postpartum. I could show you that for Michigan. I could show you that for Oklahoma. I could show you that for about a half a dozen states just based on what I could pull. And you probably have better access to your PRAMS data than what I was able to pull. Michelle's asking about the references. The whole slide set will be available to you, Michelle. So Cami is interested in the new National Transportation Plan. You want to talk about that?
Hi there. Yeah, thank you. Sorry, I was on mute for a second. I just know that all these new plans are coming out. It's great. And I know one of the issues, especially here local in Colorado, is just access to services is huge, whether it's the pregnant folks or young people or families. So it'd be nice if these plans can also just sync up with that. So as you're looking at these plans, look at the new funds that are coming out of that as well, because I think that access to service is just huge. And often gets missed. So much money is needed in the service area, but I think helping people get to and from the services is equally important. So just watch for that plan as well, because you might be able to take advantage of those monies side by side. I just don't want anyone to miss out on those funds.
So Maria's asking about the money for reopening schools, asking in addition to funding for testing and contact tracing, is immunization included? Maria, it wasn't explicitly included in the American Rescue Plan Act, but I have it on good authority that the Biden administration is figuring out how to make those funds work. They've got the vaccine money in a separate place than the education money going through the Department of Education, but they've got a lot of vaccine money. And so I think those funds for free vaccines for children will be there. The administration has those resources. It's a kind of a question of which pocket they're in. Let's see. So Alexis is asking whether she could share information as a resource. I am welcome to have you take things from my slides and show ideas that I've shared there. Make your own to-do list. Maybe you're closer to the ground. Maybe you can insert where I have generically other partners. Maybe you and your city county area can say, and X partner, X agency, X organization. If you could make those to-do lists specific to your community, I think that would be great for a lot of City Match folks to do, and share them back with us. I know the City Match team and I would love to know if you took those to-do lists and run with them. I'm doing this because I want this information to get out. I want people to use it and both help families get the services and show that these resources were needed and used. Again, if there's a bunch of money that gets left on the table that doesn't get spent, that's just all the more reason that policymakers, members of Congress can go, or in your legislature can go say, see, people didn't really need that. Or the opportunity, for families to feel the experience that the government invested in them, cared about them, cared about what happened to their kids. That changes how people view the role of government. And again, without all those severe cliffs, and not just the poorest family, I mean, really think about it. If 90%, which is the estimated, if all of the families that qualify for the child tax credit get it, 90% of families will get something. They will get money. That's incredible. I mean, this is a once in a lifetime, once in a generation opportunity to make a change in the way we invest in rather than penalize families, the way we go with education dollars first to the schools that were hardest hit, to the schools that are in communities that have been disinvested and that are that had the Title I funds, which were never enough to do the job, in the federally qualified health centers so they can open up and give people vaccines regardless of their immigration status or their income or their insurance. It's really an extraordinary opportunity. So please do use things. Yes, absolutely. Anyone else want to talk? I'm talking a lot. I think are we at time?
I think we actually had 90 minutes. So if there
All right.
is more discussion or more questions, we can carry on.
Yeah, good. Okay. I would be happy to re-show a couple of things if anybody wants to see things. I see.
I think Zoe has a hand raised.
Okay, great. Go ahead,
Hey,
Zoe.
thanks so much. I have an off-the-wall question. It's really because it's a policy question, and I really wonder how it could impact what we see. I'm from North Carolina, and this morning I started my day to hearing that there's a lot of activity in our state, much like we've been seeing in others, on barring critical race theory in public schools. And I bring this up because we're working on health equity. And so much of, and I just wonder if you've given any consideration in what we may see as we disaggregate, as we really address, historically marginalized populations. And so what may we be seeing, and is there any way that it may actually even show up in some of these federally funded streams, or might it be something that ends up, if it's federal and then the state is able to adjust it if it's community-based?
So there are layers in your question. Let me see how I can take them from the end and roll back.
What are you seeing? All this, yes.
Right.
That's it.
So the first thing that I'm seeing is that the Biden-Harris administration is committed to equity, and they don't have all of the answers any more than any of us do for what the solutions are. But I would just like to reassure you that that commitment is real. I've been working with the Maternal and Child Health Bureau on their strategic plan and working with the staff there under contract. And I have heard Michael Warren say, and I heard him say it again today, from the White House and the Secretary of Health and Human Services, they are being told, where are your equity strategies? Where is your commitment? Show us your investments. It's coming from the White House down through all of the agencies. That has never happened in our country's history. Even when Johnson was pushed into pushing the Civil Rights Act because he couldn't do anything else with the level of social unrest that was occurring. And we all know that's why he did it, right? So even then, it wasn't a president and a vice president and a Secretary of Health and Human Services who said, we are deeply committed to changing the racist underpinnings of our country and improving equity, and every arm of the federal government must have do their planning, show us their action, show us how they're changing investments, show us how that's going to start happening wherever you work. You work in transportation, you work in ag, you work in HHS, labor, education. So I don't think they have a lever. They don't have a lever to stop states from doing that. And it wouldn't probably good for them to withhold education money from since so much of this money to the hardest hit schools. You don't necessarily want them to hold it. But I do see and know that for the entire federal government, they are being charged with changing the way they do business. I just think it's extraordinary. Everybody also knows that states are going to do everything they can do to stop this. I mean, if you'd said to me 5 years ago, all this positive stuff was going to happen, I wouldn't believe you. But if you'd said to me 5 years ago that states would turn back federal unemployment money, I wouldn't. That would have been inconceivable to me, because they would have been voted out of office if they turned back unemployment money in, let's say, the Great Recession in the Obama era. It just would not have happened. Everything about politics has changed, and it's really a tough time, because your state, doing that, other states out in the West and the Midwest turning back other federal dollars, they will do that. But I think what we can do is the positive side of offsetting getting money into families' pockets, getting schools improved, getting access to health care, getting people insurance when they need it, and making sure what's delivered is delivered in an equitable, anti-biased, anti-racist way. That's the part we can deliver. I don't know, maybe that's simplistic, though. I don't know. You're on mute. You want to respond?
Just thank you. Yeah, that's encouraging. Sometimes we need to understand, sometimes it is about understanding the macro, because sometimes these micro distractions, can, create paralysis, and just to keep going and not let it
Yeah.
distract.
Yeah.
Thank you.
Yeah, absolutely. 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 Our other, I wondered if anybody was seeing some of this, start to happen. I mean, are there conversations among community activists or in your health department, or are you starting to see and feel these changes? And frankly, a lot of this money's gone out the door. The money to schools went out the door 2 weeks after the bill was signed. It's been out a month for schools to start going. The mental health money is going out soon. Money went out for community health worker investments, for communities to respond. Have you seen or felt any of these? Anybody? Do you know who you might contact? Let's see. Yep. Oh, thanks, Jessica. So B's saying not yet. I think it's maybe not yet, but one of the reasons I kept saying influence the decision makers. Find out what's decisions being made. That's great. Nicole, you want to talk about Milwaukee?
Sure. Hi, everybody. I'm Nicole. I work for the Milwaukee Health Department. And so I'm a city employee. And one of the feedbacks that was given when Biden came into office was that the community didn't have any input on the decision making or where dollars went. So in retrospect, there are like a lot of places that it went. People would not have agreed for it to go on those places. Of course, the health department got a big chunk of that, but now we get the state. We have state funding, we have city funding. Thankfully, our people in Congress and the Senate and things have been working to not only get money for the state of Wisconsin, but one of the nuances of living here is that a lot of things go to Madison and don't come to Milwaukee. I'm from Chicago, so I didn't know any of these things. So just saying that, yeah, we're a big city, but we have a need much greater, that may be greater in Madison. So really speaking to our experience in order to get dollars for that. I think we had our first meeting in May. I haven't attended it, but I think they're trying to gather people to be part of that committee to say, hey, these are some of the needs, and using the older people and their constituents to influence and inform some of those decisions.
I think that's a great example, Nicole. And unfortunately, we've all learned a lot about the dilemmas of Milwaukee over the past couple of years. I'm glad we're all learning, but I'm not glad that there are so many dilemmas that are related to racism in Milwaukee. So I'm noticing that there's the key point of what you're saying, though, is about people coming together and community coming together and having a task force and having the conversation. And I think that gives you a lever to have greater influence over the state decision making and how dollars come to you. The other thing that it can do is have you prepared when there are dollars coming down. Say, let's just say CDC gave about 3 weeks for states and communities to put in these proposals for community health workers. Well, if that group was already organized and you already had people who could work with the data, who understood how to put the contiguous census tracts together, or who understood the need for community health workers, then you got kind of a ready-made group. I mean, like finding the grant writer is not the hard part. Finding the people who want to set out the priorities for how those community health workers would be used and so on is the challenge often. So when you have a group this already formed, you can be ready when these opportunities come down, and they're going to come down. They're going to keep coming down fast and heavy over the rest of the year. I think if the American Families Plan Act we're still, the money for the community health workers that just came in, that was the CARES Act. That was like a year ago. That isn't even the American Rescue. So there's these opportunities for states and county, city areas to apply for funds will come. And if there's a task force, if there's a real community-based entity group that can guide those, I think that's great. Chelsea, do you want to say anything more about Texas and community health workers?
Hi, I just wanted to say that it's really exciting to have these things happening personally, because as a maternal and child health program specialist that we have in our region alone, we have 37 counties and there's only 4 of us. So it's a lot to cover, you can imagine. So we're really excited to have things happening.
Great, good to know. Nicole's also talking about the mayor. That's good, encouraging the department to look outside of those dollars for more support. Absolutely. And so thinking about that interchange, the two that we thought about, Nicole with, you know, the city county government going, you know, being prepared to go to the state and help set priorities and make demands. And then, you know, and Chelsea thinking about, you know, what's the opportunity there in that region and local area, you know, to have an interchange, a dialogue with the state. Again, one of the things we've been really concerned about is so much money coming down from the federal government. I mean, that, did you tally, you know, we were up around $100 billion in public health, not including the community health centers and the workforce training. That's a lot of money coming into health departments. And we all know you know, there's procurement, there's priority setting, there are hiring freezes, there are all kinds of challenges for public health and even spending the money. And so I think to the extent that you can help set priorities, you can let people know what local priorities are. You can, you know, really put a face on the challenge. Talk about what's going on in your community. Describe those postpartum moms. Describe the families having children. Describe the families, you know, who lost their health coverage. I think that really helps guide investments. One of the things that a lot of us, is kind of a group of us nationally as child advocates who've been meeting on this stuff, we're worried that health departments would just say, oh, well, again, we're gonna hire a bunch of people and we're gonna send them to nursing homes, and we're gonna have these, you know, these kind of community-based things that are for adults with chronic health conditions or just for the homeless, and not think about the overall impact on, you know, in their mind, maybe it's just about getting people vaccinated or testing, as opposed to thinking about the way that families were affected by the COVID crisis. You know, from the social isolation and the economic impact. And these dollars are about, I mean, they're about getting vaccines into people. They're about containing the COVID pandemic, but they're also about building back better and putting a recovery in place. And that's so much of what you can help inform about families, about birthing people, about children. Other thoughts, questions, concerns? Action at your level? I might just, since it was asked, I'm going to go back to this one. Hold on, I'm going to chat up at the same time. So it was asked about the resources, and so I'll just tell you how this works. These are kind of my additional resources. A lot of these have to do with maternal health as well as to the American Rescue Plan Act. So this one, for example, there was a Center for Medicaid and Medicare Services panel that met about maternal health and infant health to reduce maternal and infant mortality in Medicaid. The report came out in December. It hasn't gotten much attention. I think it can be useful to you. A lot of several blogs here about perinatal insurance and the coverage of pregnant women. and you know, who's doing, like the Commonwealth Fund is doing tracking policies to improve maternal health. David Willis and Stephanie Doyle and I wrote a guide to leveraging opportunities between Title V and Medicaid for promoting social emotional development. The title sounds like it's about mental health, and it touches on mental health, but it's mostly about starting with babies and how are we going to make primary care work for families. And then the roadmap to child poverty, the Academy of Sciences, which it gives a look behind, you know, how did we get to understand what policies could help reduce child poverty? And then I'm also going to say to you, in addition to that, you know, as you go back through them, like, so on this one, the White House statement, the White House fact sheet on the American Families Plan, there's as well as statements by other organizations. And you can actually, there's a congressional bill on the House side. So if you like to read legislation, so you can look at the references at the end, but there are also references all the way throughout. If you wanted to see how much money your state got in the IDEA program, the estimates are posted on a website. So, and likewise, those for education are posted on a website. Other questions?
I have a question. This is Delisha from Milwaukee.
Hi.
Hi. It's related but unrelated when we're talking about vaccinating our populations. There's a real fear and uncertainty among youth and birthing populations about vaccinating. Like they're totally okay with their older family members doing it, but they're like, oh, I might still have children, or I'm unsure about my 16-year-old taking this vaccine. How will it impact them in the future? Where's the research? So with there being so many people on this call from different cities, is there a website or any research currently being done on how, or people being followed on how the vaccine will or isn't affecting younger populations so that I can help calm some of the fears and uncertainty?
Yes, absolutely, Lisa. Thank you for that question. You know, that's actually happening in my family too. I'm old. I'm getting older, as we all are. But I have great nieces and nephews who are in their childbearing years, and they live in Indiana, and they have a lot of these concerns. And so I've thought a lot about how even to persuade them. But at the larger level, I think the best way to keep up on that is CDC, because they keep linking in the data. And so I often go to CDC first, and they will send me back out to an article. The other side of what I'm using, and the reason I put together that slightly complicated slide for you about the impact on pregnant women, is that I don't think that story is being told. And you may have a better way to tell it. But I think the fact that particularly for women of color, getting COVID while they were pregnant, that they were more likely to end up in the ICU, that they were more likely to end up needing the ventilator, and they were more likely to end up dead. I think that's a story that has not been told to birthing people. And so I think if we can make an I mean, I don't want to be overly dramatic about it, but 2.5 times to 6.5 times the risk is certainly something worth communicating about. So I think the idea that, you know, birthing without being protected by the vaccine, there's no evidence that the vaccine is having adverse effects. Obviously, we don't have long-term data, but there's no short-term data. And for a long time, people were feeling like, well, it wasn't being transmitted to the babies. There was no evidence. They started right away with China, looking at whether or not there was mother-to-infant transmission. Many of you have participated in City Match conversations about mother-to-infant HIV transmission. Viruses can transmit from mother to fetus, and it doesn't seem, we don't have any data that suggests that that's the case. So I think people felt complacent because of this. Now we have this really big study in the United States, you know, not in India, not in China, not in Germany, not in England, but in the United States. What happened to pregnant women who got COVID? And what we see is the elevated risk for women of color, but the elevated risk for all of them for having a more severe, more complicated, perhaps really serious set of consequences. And Again, I think that's a story that has to be told. And it's all relative risk. I'm really risk averse. You know, I don't drive over the speed limit. I wear my sunscreen every day. Other people just don't. So in the end, there are people who are willing to take the risk, but I think they have to understand their risks. And we've not, I mean, we had a whole year under the last administration where the real risks were not being explained. We have data, we have an opportunity in public health to communicate about the risks. So the sites are there. The data are all at the CDC website, but the link to that is in the slides directly to the study. Hope that helps. Yep, the good CDC. Thank you, Jessica. The Vaccine Confidence webpage. Other thoughts? I need to go a little deeper while you're thinking maybe of other questions or things you want to tell us all about the postpartum coverage. I think the postpartum coverage is really important. And I really applaud all the advocates who made that happen. At the same time, what I know, and I suspect most of you know, is that if women then don't get the postpartum visit, if they don't get the immediate attention, if they don't have a health provider who listens to them, if they don't get recommended standard of care because they're a woman of color, the coverage isn't going to be good enough to keep them from having mortality or severe morbidity. And so I think it's going to be on all of us in MCH to keep, and that's why I put those other slides in there about, you know, this is not just about the policy. We got these layers of change, right? We get the policy, we get the coverage, and that's like the first hurdle. Imagine you're running around the track. Well, you got that first hurdle. Well, if we clear that first hurdle, that's good. But the next hurdle may be lack of equitable access, or in a rural area, lack of access. And then the next hurdle may be that the provider that the woman has access to engages in biased and racist behavior, or doesn't listen to her because she's a person of color, or because she's a teenager, or because she looks poor. And so I think just for us, you know, MCH leaders to keep remembering, we got to get the coverage, but we got to change these other things too. And you have much greater opportunity to change those things at the local level than people like me who are kind of national advocates. Yes, thank you for posting, Jessica. She's got the, Jessica, do you want to say anything about your reading of the science? I know you've probably been following it.
I haven't dove into it, but I figured let me find it, because if folks can have like direct access to it and pull it up, then they'll have it more at their fingertips. So if you just want to learn a little bit more about the preliminary things that folks are seeing in pregnant women, and they have women who were and were not diagnosed with the COVID-19 infection, just to show the difference in their outcomes. So we're still learning as we go. So enough time hasn't passed yet for everything.
Right. And the study that I cited, that I made that chart from, is the CDC MMWR studies there. It's from November. Any other thoughts? It's been really good talking to you. I'm glad to learn from you. I'm glad to learn you're making progress on postpartum coverage. And congratulations to those who got that work done. I'm really just so always humbled by the work that you all do at the community level. It just takes incredible determination and just to stay in your roles. And I think through this past year, it's really my pleasure to talk to you. So Kara, you may have a minute or two of housekeeping. I think I'm done.
Well, I just, first of all, want to thank you so much, Kay. for sharing the wealth of knowledge today that you did, and also for diving deeper into discussion. I think it was really, really wonderful. We will be sending out a brief evaluation to everyone. So if you would please let us know your thoughts on the webinar format and things, that would be helpful. And of course, as promised, we'll be sharing case slides as well. So thank you so much, everyone. Have a great rest of your week.